Okay, guys, so we are on chapter 7. This, of course, is going to focus on the femur and pelvic girdle. And as with every chapter, we're going to start with the anatomy section first, get all that mastered before we move on to the positioning. And hey, good news, guys. We're on the last chapter of the semester. We're about to wrap up Rad Pro 2. And a great one to end it on because honestly, when it comes to the pelvis and femur, it's a lot less anatomy overall to memorize compared to the other chapters. Yet still very important anatomy. It's a big key to what we do because the pelvis itself overlaps with so many different exams that we go over. For example, when we get to spine next semester, when we get to L spine, you got all that pelvis anatomy in there. When we talk about SI joints, all the pelvis anatomy is there. Sacrum and coccyx, all the pelvis anatomy is there. So a ton of overlap in that pelvic girdle. Very important anatomy, but not an extreme amount like we just went over for the lower extremities. So good news on that front. Okay, so when we talk about the hip and proximal femur, of course, we are talking about the entire pelvic area, even though you see only one side of the pelvis right here in one whole leg. But pelvis would be everything together. One side would be basically talking about a hip. When you talk about the left or right side of the pelvis, you're talking about the hip area. But we're focused on the femur all the way up to the top of that pelvis on this chapter. We, of course, have the lower leg, foot, and ankle down here. That's what we went over on the last chapter. But we're talking about from the area of the patella, which is this distal end of the femur. We have your condyles, your epicondyles, your intercondylar fossa, all that wonderful stuff we talked about, moving all the way up proximally to the tip top of that iliac crest. And all of us should know by now what an iliac crest is. At least I sure hope so. That's one of those great palpation points that you guys have done a million times by now. At least it feels like a million times. What else do we have in this pelvic girdle area? We have a SI joint, hip joint, pubic symphysis, 3 major landmarks. But we're going to break all this down a lot further as we single these parts out individually. Now, when we talk about the pelvic area right here, I'm about to draw a circle around it for you. When we talk about this area right here, including the head of the femur and that joint, that's what we call the pelvic girdle. It's another term that we use to describe that area of the pelvic girdle. So you may see that terminology sometimes. Pelvic girdle is referring to pelvis and the femur attached to that hip joint together, the proximal femur, to be specific. So speaking of proximal femur, that's where we're going to start right here. We got some major landmarks. A few of these we went over on the last chapter just briefly, but now we got to really focus in on them because every single one of these landmarks, in fact, to my memory, every landmark we're going to name on the pelvis and femur today is going to be included on x-rays. So we need to make sure we memorize those diagrams very carefully because we will be able to see all this anatomy very clearly on x-rays. So starting with the most proximal end, we have a little, I'll start with the head here. This rounded portion of the femur, of course, is the head, much like other pieces of anatomy we've talked about, like the head of the humerus and other areas of the body. That rounded portion would be the head. Now, on the top of the head, right in the center, there's a little tiny hole right here. A little hard to see unless you're looking directly at it, but that little tiny hole is maybe what we call the fovea capitis. Fovea capitis, and depending on how the femur is positioned on x-ray, we can actually visualize that little opening quite well. That tiny little hole on the tip of the head there is that fovea capitis. Now let's just move a little more distally here. Much like all the bones we've been going over this semester, this portion of the femur, this thin portion, is going to be, of course, called the neck. The neck. And by the way, this is an anterior view here. This is a posterior view. You can see the neck anteriorly and posteriorly, side by side here. You can see the head anteriorly, posteriorly. But you'll notice you can only see the fovea capitis in that posterior view. And that's going to be a little more important once we start talking about the positioning because you can see that on x-ray on certain positions. Now we have 2 big landmarks here. We always want to make sure we know these very, very distinctly because depending on how we position the leg for different x-rays, these 2 landmarks will end up in profile on different positions. We'll break that down as we get a little further. But those 2 landmarks are the greater trochanter and the lesser trochanter. By the way, that's the only terms for those. There's not multiple names like a lot of the stuff we've talked about. Not to be confused, by the way, with the greater and lesser tubercles. People mix those terms up quite a bit. Make sure you know when you hear the word tuberosity, greater and lesser, that's the humerus. When we talk about the femur, greater and lesser trochanter is the terms we're going to use. Similar in concept to those tuberosities, by the way, but on the femoral area, they're referred to as trochanters. Then, of course, as you move down the femur more and more distally, the long, thin portion in the middle would be the body or the shaft, just like so much more anatomy we've talked about. And then we have one more very distinct piece of anatomy that we see on the posterior view. But whenever we look at this on x-rays, we can see this line right here very prominently, this ridge. That's going to be what we call the intertrochanteric crest. That is the crest or protrusion in between the greater trochanter and the lesser trochanter on the posterior side of the femur. I'll say it again. That is the raised ridge in between the greater and lesser trochanter on the posterior surface of the femur. Very distinct landmark, and we can visualize that on x-rays, even on an AP view. You can see straight through the bone and make out that very prominent line. So all of these pieces of anatomy we just named here, these are all easily visualized on our x-rays, and they're very important landmarks when it comes to the different positioning that we do as far as how we rotate the foot, rotate the leg, AP versus lateral, cross table, so on and so forth. So that's going to be your proximal femur anatomy. Now let's start breaking down the pelvis. Pelvis has a lot of very important landmarks that we have to memorize. Before we start breaking that down, we've got certain sections of the pelvic area that we have to label. When we talk about this area, let me get the drawing tool out here. This area of the pelvis, from the SI joints, went all the way around here, not including the femur. It's this light blue area that I'm highlighting with the red. This area right here that I have highlighted in red is going to be our two hip bones. And that is two separate hip bones, by the way. There's not one hip bone, but two hip bones fused together at the area of the sacrum and the pubic symphysis. You have a left and right hip bone. They also go by two other pieces of terminology you need to make sure that you know. They can be referred to as the ossa coxae, or innominate bones. The two hip bones also go by the terminology of the ossa coxae and the innominate bones. Now, of course, in between these two hip bones, we have two more prominent bones that we've talked a little bit about in the past. We have the sacrum right here in the middle, and then we have the coccyx down here, the little tip, little tailbone, also known as the coccyx. So there's three portions of that pelvic area are the two hip bones, the sacrum, and the coccyx, or rather the four sections, because there's two hip bones. Two hip bones, one sacrum, one coccyx, all making up the pelvis.
Mr. Donahue, I have a question.
Yes,
you said that the hip bones, there are two bones fused together, the sacrum, and what else?
And the pubic symphysis.
Pubic. Okay, thank you.
So if you put a line right here, that would split those into two parts, as you can see. And of course, if you separate it from the sacrum, took that out, you have a hip bone over here, hip bone over here. So make sure you know there's four major bones, including that pelvis. Okay, so we're going to break down the parts of the hip bones. We're not going to talk about the sacrum and coccyx more specifically until next semester, but the hip bones themselves break down into three separate sections. Now that's on each side, by the way. We're only looking at the left side here. At the right side, it's the same exact thing. When we talk about the iliac crest down to the upper half of the acetabulum, that's what we refer to as the ilium. This is the ilium of the hip bone. It's highlighted in green. This area that's in the purple, which is the lower half of the acetabulum, and the right half of this area to the side of the obturator foramen, is what we call the ischium. The ischium. And the third area, as you go close to the pubic symphysis, this is what we call the pubis. So there are three major parts of that hip bone that's included on both sides, by the way. So therefore you have 2 ilium, 2 ischium, and 2 pubis, if we combine the two. 3 major sections of those hip bones, 3 incredibly important terms to make sure you know. That's big gold star questions right there. The 3 sections of that hip bone, ilium, ischium, pubis, and make sure you know where those sections are in the highlighted portions here. Also, you see already labeled here is what's called the acetabulum. The acetabulum is that opening that you see right here, guys, that the head of the femur fits into. So the femur is obviously taken out of the socket right here on this diagram, but the head of the femur fits right into that acetabulum to form that hip joint area. Now you might be asking, what's this picture on the right? If I remove this section of the hip bone, like I took it off the sacrum, removed it from the pubic symphysis, and turned it on its side, that's what I'm looking at right there. See, here's the acetabulum from an AP view. This is the hip if I'm looking at it sideways, like in a lateral view. Like if the patient was lying on their lateral side, like a lateral chest, lateral abdomen, whatever, we're looking at it from the side. This is the front of the pelvis. This is the back of the pelvis. We still have those 3 sections divided up right here, the ilium, the ischium, and the pubis, with that acetabulum right in the middle right there. Now, in this view, you can see one very clear thing that we need to make sure we recognize. Let's look at that acetabulum a little closer. What's something very distinct about that acetabulum without me saying anything that someone can point out? Does anyone see something peculiar there or something very important?
All 3 of them connect.
Very good. All 3 of those hip bone portions connect at the acetabulum. That's a very important thing to remember. All 3 of those sections connect there at the acetabulum. You want to say it fancy, it's a convergence of all 3 parts of the hip bone. Okay, so still looking at that lateral view, guys, we're going to start breaking down the anatomy of those 3 sections because each section has their own distinct anatomy. Some of these should look pretty familiar. We've talked about a lot of these before with a few new ones thrown in. Of course, if we start at the very top, there is that wonderful iliac crest, which we use for great centering on our KUBs. At least I hope you're centering your KUBs there, palpating those iliac crests. Now, this main area, that flat portion of the pelvis or the hip, is the ala, also called the wing. As we move a little bit further downward and we're closer to the acetabulum, the ala is then labeled as the body. Make sure you know the difference. The upper portion is the ala. The mid portion closer to the acetabulum is the body, the ilium. Now, by the way, when you're labeling this, you don't have to tell me like that's the ala of the ilium, the body of the ilium. As long as you tell me that's the ala of the pelvis, or ala of the, I want you to say ala of the pelvis, ala of the body, body of the pelvis. That's acceptable for me. It's all part of the pelvis. That's the easiest way to label that, in my opinion. But do know that is technically on the ilium portion of that pelvis. Now let's go to the anterior side here. This is another one that you guys should be familiar with, the as is. The as is that first little indentation as we move our hands down beyond the iliac crest. And that does stand for anterior superior iliac spine. Make sure you know that entire term, but you can use the abbreviation if you're labeling that for me on the diagram. Anterior superior iliac spine, also known as the as is. Now, as we move more inferiorly, there's another little notch that's right above the acetabulum. That's what we call the anterior inferior iliac spine, or abbreviated to the AIIS. So we have an ASIS, but we also have an AIIS. Very easy to mix up. Superior, obviously, is the superior one. Inferior is the inferior little bump. You can palpate these on yourself or your patients. So as is and AIIS. We keep moving inferior. We, of course, have the acetabulum once again, which is where the head of that femur fits into that notch, forming our hip joints. Now let's go to the posterior side. Now, you can't really palpate these because there's a little bit too much tissue back there, but we also have a posterior superior iliac spine, abbreviated as the PSIS. Then inferior to that, just like the anterior side, we have a posterior inferior iliac spine, PIIS. Once again, you can use the abbreviations, but make sure you know what those stand for as well, because I will use those words interchangeably. I don't want them to throw you off. So PSIS, PIIS on the posterior side, ASIS, AIIS on the anterior side of that hip bone or pelvis. Now, most likely on an x-ray, you're going to see the ASIS and the AIIS. The PSIS and the PIIS are a little bit more harder to see, except for only very distinct views that we're going to go through towards the end of the chapter. They're a little bit more niche to find. Most of the time, it'll be the ASIS and the AIIS that you can readily identify on an x-ray. So just to see if we're paying attention, let's see if you can label these. You know the drill. I'm going to start with the letter A, and I'm just going to jump around here. Let's start with A. Let's see. Tracy, what is A referring to?
The acetabulum. Correct, the
acetabulum. Let's go to Son. Son, what is B?
B is the inferior iliac spine.
Correct, or the AIIS. Well, let's go to C. John, what is C?
The anterior superior iliac spine.
Correct, or ASIS. Correct. Let's see. Jaleisha, what is D?
Who's gonna probably, is that the iliac crest?
Yes, it is. Let's go to Expede. What is E?
Ala wing.
Ala or wing, correct. And let's see. Dian, what is F?
The body.
The body, correct. We've got two more here. Let's see. Amy, what is G?
Posterior iliac spine.
Posterior what? Iliac spine. Posterior superior iliac spine. Good. A PSIS. And finally, Marcella, what is H? What would H be referring to?
I'm not sure.
That's going to be the PIIS, or the posterior inferior iliac spine. Good overall. Very important anatomy there, guys. Know those landmarks, especially the difference between as is, AIIS, PSIS, PIIS. Focus on those very closely. Son, can you mute your mic? Make sure you focus on those very, very carefully, because those four landmarks are the ones I see people mix up the most on this chapter, because they have very similar names, but they're very distinct locations. Know the difference between those. Okay, let's go to the ischial area. We have some more anatomy here. This is the ischial area. We're a little bit more distally. We're going to start right here at the top. We have this very prominent, this is still that lateral view of the pelvis, by the way. We're looking at this very distinct notch right here that goes in. It's a really deep indentation. That's what we call the greater sciatic notch. Does anyone know what that little notch holds? A lot of older people have this issue. Keyword sciatic. Yes, the sciatic nerve. If you ever heard the sciatic nerve, people have sciatic nerve pain. The sciatic nerves go through those sciatic notches. So we have our greater sciatic notch. Let's move inferiorly. We have a little spike here that we call the ischial spine. This is an important landmark because we can view this ischial spine in an AP pelvis, through the pelvic brim. If you don't know what the pelvic brim is yet, we're going to go over that in a little bit. That circular area in the middle of the pelvis, you can see the tip of that ischial spine. So that's an important landmark. Moving a little bit more inferior, we have the lesser sciatic notch. Not to be confused with the greater. The greater is very large. The lesser is very small. As we keep moving inferior, we have another very prominent landmark that we can see on our x-rays. It's called the ischial tuberosity. There's always got to be a tuberosity in there on every one of these chapters. Ischial tuberosity is on the inferior portion of the pelvis. I'll show you what that looks like on an AP. It's a little easier to see on an AP. And then this area, right before we get to the pubis, is what we call the ramus. And the ramus has a superior and inferior portion that we're going to go over on the AP view here in a little bit. Then, of course, we have our acetabulum, and we also have, as far as the ischium is concerned, if we talk about the upper portion of the ischium, it's called the upper body. The lower portion of the ischium is called the lower body. This is talking about the sections of that ischium. Upper portion is upper body, lower portion is lower body. The big ones I want you to really focus on, even though these are all important, are ischial spine, ischial tuberosity, and ramus. Because we see those quite a bit on our x-rays. And now we're going to break down the pubis. Here we see an AP view versus lateral view of that pelvis once again. The pubis is the area on the medial portion right here, close to the pubic symphysis. Now this portion over here by the acetabulum is going to be what we call the body of the pubis. The upper portion of the pubis right here by the top of the brim, the bottom of the brim right here where I have my cursor, that's the superior ramus. The bottom would be the inferior ramus. If you remember saying ramus, the ramus has two parts. We have the superior ramus and the inferior ramus. I went over here. Here's the superior ramus. Here's the inferior ramus. And then the body right over here. Right here in the middle, of course, is that pubic symphysis. That's a cartilage between both pubises or pubi that connects those hip bones together. And you guys remember this from first semester, those two big holes you see right there, those, of course, are obturator foramina. Singular would be obturator foramen. Obturator foramina or obturator foramen, singular. If this was a big mask, I always think the pelvis looks like a mask. That would be the two eye holes right there. You put a pelvis over your head, looks like you're wearing a mask. I don't recommend putting a pelvis on your head, but if you're feeling entertained, there you go.
So the ramus is kind of part of both the ischium and the pubis?
Yeah, it overlaps a little
Okay.
bit. Yes. Oh, and by the way, if you remember when I said iliac spine, guys, I'm sorry, ischial spine. There's that ischial spine that we view on that AP view jutting into the middle there. See those two little bumps? That's that ischial spine we just talked about on the ischium. We can see that on our x-rays. And this is a few more of the anatomy that we've already went over. We're looking at it with AP and the lateral in comparison. We, of course, have the iliac crests. Another way you can see it labeled is the crest of the ilium, but we know it as iliac crest. Therefore, I recommend keep calling it iliac crest because that's what you're familiar with. Here is that anterior superior iliac spine. If you notice on the AP, we can only see the as is, but if I go to the lateral view, I can see the AIIS right here, even though it's not labeled. So there's as is. AIIS is right under it. You'll also notice what else is invisible on the AP. We can't see the PSIS or the PIIS, but if I turn that hip lateral, there they are right here. Same with those notches. Here's that greater sciatic notch. lesser sciatic notch. Can't see it on the AP, but I can see them on the lateral. But we can see both. And so we can see the the ischial spine on the AP and the lateral. Here's the ischial spine laterally. Here's the ischial spine, this AP view right here, jutting into the inside of that pelvic brim. For symphysis pubis, we can do that on both. And here's a big one here, guys. Don't forget this anatomy, the ischial tuberosity, not to be confused with that inferior ramus. Let me draw you a little bit of color diagram here, because people mix these up quite a bit too. This area right here that I'm putting in red is the ischial tuberosity. The area that I'm putting in blue is the inferior ramus. So this blue area is the inferior ramus. This red area is the ischial tuberosity. Two different landmarks right there in the inferior portion of that pelvis. So I would write that in your book. I would just recommend, if you want to color code that, write that in your book, just because I see people mix those up quite a bit as well. Inferior ramus versus ischial tuberosity. And of course, there's our greater trochanter. Our
Mr.
lesser
Donahue, I have a question.
Yes.
Is it inferior or superior? Because in the book, it says superior.
It's saying this is superior ramus.
Yeah.
That's mismarked. Superior ramus is up here.
Okay. Thank you.
Yeah, fix that in your books, guys. If you heard what Amy said, the superior ramus is up here, where I'm putting this orange. Orange is superior ramus, blue is inferior ramus, red is ischial tuberosity. Does the book really say that? That surprises me. That's a major labeling issue.
It doesn't say it in the diagram, but in the description, it says it on there.
Okay. Well, I would do a little color diagram like I did right here, guys. Those are three major landmarks. Make sure you know those three distinct landmarks. Easy to mix those up. Okay, so when we talk about the brim area of the pelvis, that circular area that's very open, we have what's called a false versus true pelvis. When we talk about the false pelvis, it also goes by the terminology of greater pelvis. Now, what am I referring to? I'm referring to all this area on the outside of this blue dotted line. This is all the greater or the false pelvis. Now, the area inside the blue line, this big opening, that's what we call the lesser or the true pelvis. Also called, another terminology for females, that's the birth canal. Birth canal. For females only. And then when I talk about that dotted line itself, guys, this circle going around, that edge that we can draw a nice oval shape with, that's what we call the brim of the pelvis. Or the pelvic brim. It's also what it's labeled as sometimes. So greater or false outside the blue line, lesser or true inside the blue line, and then the blue line itself is the brim of our pelvis. And like I said before, that's also referred to as the birth canal. That'd be for females only. Of course, the female pelvis is shaped differently than the male pelvis. We're going to talk about those differences in a minute, because for a female to give birth, the pelvis has to be a more wide oval shape compared to a male, which is going to be a lot more long oval shaped. We'll get into those differences here in a minute. Now you'll see a couple more pieces of terminology here. When we refer to this top portion of the pelvis above this dotted line, sometimes you'll hear that referred to as the inlet. This area where the triangle is also sometimes referred to as the outlet. I don't expect you to know those. We're going to talk about inlet and outlet views and positioning, which will have more distinction on that a little later. I do want you to focus on the difference between the greater, lesser, true, false, and that pelvic brim, also known as the birth canal. That's the more important terms to make sure you know.
Do we need to know the functions for the greater and lesser pelvis?
Not as of yet, no. Just make sure you know the terminology and where they're located. And by the way, if you can just picture in your head here, of course you see a baby here in the mom's tummy. As it passes through that birth canal, we have that pubic symphysis right there with the cartilage because it's going to expand a little bit, allowing that baby to travel safely outside the mom when she's giving birth. That cartilage allows that little bit of movement for that pelvis to expand properly. That's just showing you a little bit more what that looks like. If this was an X-ray, we'll show you what the X-rays look like here in a minute. Typically, most babies will have their head inferior with the feet superior. They'll lay in the tummy just like that. They'll pass through that birth canal when the mom gives birth. That's showing you how it looks like laterally. If everything's going as it should be, baby's going to pass head first through the birth canal, out the mom. If it goes feet first, it's what we call a breech birth. Usually they have to assist that baby coming out. And there's what the X-rays look like right there. I think I've shown y'all pictures like this before. I always say it looks like an alien inside the tummy a little bit. I always thought it looks like an alien in there. I've done a few X-rays in my career where I've had to take X-rays of a baby inside the abdomen like that, and they do look exactly like that. You can see the bones are not formed all the way. You can see all the little spaces between the bones, all that cartilage in the baby. And they usually always lay just like that, with their spine curving, their head right there in that pelvic brim, So when it's ready to come out, it passes straight through. Once again, this would be a last resort. You'd never want to actually take X-rays of a pregnant, unless it's like an emergency situation. The mom must have an X-ray done. Sorry, question?
I know I was going to say, I know it's already past story time, but I actually did one X-ray on a pregnant patient. They order it at the EC only once.
Oh, go ahead and tell it.
Well, she had a car accident. Her husband was driving, but she could walk. She was fine. But they ordered an X-ray, and she was pregnant, and we just verified with the doctor, and he's like, yes, I need to see. I thought it was cool.
So did it look like the picture you're seeing here?
Yeah, like a small, like it looked like very small. Like she wasn't that many months either. I think she was like 6.
So what was the reason they were doing the X-ray?
They didn't specify. They just had it, and the tech called to verify, and they were like, no, that's what we want. Because, like, we could tell she was pregnant, and we just called, and they were like, no, that's what we want. But they didn't specify why.
Very interesting. It must have been something serious then, because typically they wouldn't do that unless there's something really serious going on. Maybe they were concerned about, like, an internal injury or something. I'm sorry about the background noise. Can y'all hear that? Hold on. Sorry, they're doing some construction in my house right now, so it's gonna be noisy. I apologize. I'll mute it when it gets too noisy. Okay. See, I knew y'all had some stories out there. Yeah, at least one good story there. Thank you, Betty. All right, so let's talk a little bit more about the gender differences. There are some very important things we need to make sure we note here when we're talking about the female pelvis versus the male pelvis. Now, of course, the general shape, female pelvis is going to be wider than a male pelvis. The angle of the pubic arch is going to be different as well. When we talk about the pubic arch, that's this area right here where the pubic symphysis is located. For females, the pubic arch is going to be what we call an obtuse angle. That means it's going to be at greater than 90 degrees, the way it arches right here. For males, it's going to be a more acute angle. That means it's going to be lesser than 90 degrees. It's going to be a very sharp angle. It'll make more of a triangle. And then we look at the shape of the inlet. Once again, it's talking about this portion right here. The inlet's going to be this area basically of the sacrum and the coccyx. If you notice on females, the sacrum and coccyx actually extend more posteriorly versus a male. The sacrum and coccyx actually curve more anteriorly, almost comes up to a hook shape. And who can tell me what the main reason for that would be? Why do you think that the male and female inlet is shaped different? Same concept we've been talking about. Anybody?
Because of birth.
Females have babies. The birth
For having babies, right? Because, for example, if a male had a baby in here and the male was giving birth, the baby would actually get stuck and cut up by the coccyx because it curves inward, curves more anteriorly. For females, it curves more posteriorly, allowing that baby to travel safely through that pelvic area. Of course, with males, it wouldn't fit anyway because males have a much more narrow pelvis in comparison to females. And we can see this on our x-rays as well. There's also a few, there's another little indication we'll show you when I talk about my little, my cheat codes. There's a little cheat code for male versus female pelvis because you do need to make sure you know the difference because the registry will throw you a question up there. It says, is this a male or female pelvis? You got to be able to label that correctly. Now let's look right here. So talking about what we just spoke about, not as clear as the pretty cartoon diagram, yes? A little bit harder to tell a difference.
Female, male.
Who can tell me which one's male, which one's female, first of all? Then I want you to explain why. Anybody want to take a shot at it?
It's A male and
A is the male.
and then B is female.
Yeah.
Correct. So I don't know who went first there, but who can explain why A is a male?
Because
Well,
it's
I
more
can
narrow
tell
inside.
Only by B. B is more the angle is wider.
Correct. That pelvic brim is much wider. Well, it actually looks almost similar on the x-ray, right? But it is a little bit wider, yes.
And it's more oval looking in the brim.
It's more of a wide oval, correct. Correct. How about down here? Do we have a different angle? In the pubic symphysis? We have that acute versus obtuse angle. Now that inlet that we talked about before, hold on guys. Sorry about that, I didn't want that to blow your ears out. So we have the angle there at the bottom of the pelvis, but also when we talk about the inlet's not very visible on the x-ray. Remember I talked about the little cheat code? Now, most of the time, guys, when you do a pelvis x-ray, you can see male anatomy very clearly versus female anatomy. You can see the penis very distinctly outlined on a male pelvis versus not on a female, but also what you'll see a lot is on male pelvis x-rays, they'll almost always shield right here to cover up the testes. Females, they're not going to use a shield. It's a little cheat code you can look for. If you're just really not seeing the other things, like you're not seeing the angles. I promise it's only for this week, guys. That's going to be, the construction's going to be over. So if you're really having trouble looking at that pelvic brim and the angle, the obtuse versus acute, look for that shield or look for the distinct male anatomy. That can help you identify male versus female pelvis as well. That's showing you a little bit more. One other thing you can look for on female patients, guys, is IUDs, birth control. Sometimes you can see that on the pelvis x-rays. And here's what I was talking about earlier, guys. This is an example of the male anatomy being covered up with a shield. If you see that, that's usually code for a male patient because you would not shield a female pelvis because the female sex organs are directly on top of the pelvis. You wouldn't want to use a shield because it's going to obstruct your actual pelvis x-ray. But you can really see the difference between the pelvic brim here, guys. You see that? Look how wide the female is. Look how narrow the male is. Look at the angle down here by the pubic symphysis. See how wide it is versus how narrow it is on the male. And then once again, that inlet, not as easy to see, but there is a distinct difference there as well. By the way, does anyone know what in the world that is? Those arrows? You ever seen that before?
IUD.
It's not an IUD.
No, it looks like one.
That's what we see on the female here. This is a male.
No, I was looking at the female. I wasn't looking at the
You're correct on the female one, but what is that?
a catheter.
Not a catheter.
I'm guessing over here.
That's a good guess. Good guess. You'll see this in a lot of elderly, senior male patients. That's a penile implant. Penile implant. Have you ever heard of elderly men getting penile implants? That's what that is. It shows up on X-rays. Looks like just like a little, like umbrella kind of, right there. And then one more time there, showing that once again, guys. There's that long oval shape on the males, very narrow. There's the wide oval shape on the females, very wide. There's the sharp 90-degree, less than 90-degree angle on the males, greater than 90-degree angle on the females. Make sure you know that difference, guys. I'm showing it over and over again because it is very important to make sure you can tell the difference between those two pelvises, male versus female. One of those gold star questions, as I like to say. All right, now this looks fun. This looks really fun. Let's see how we do here. Who have I not picked on yet? Let's see. I'm going to start with Aurora. Aurora, what is A?
A is the iliac crest.
That is the iliac crest. You are correct. Let's go to Daniel. Daniel, what is B? What do you think B is?
The as is.
Very good. That's the as is, ASIS. Let's see here. What about C? Let's go to C. That's going to be for Asias. What is C?
The upper body.
The upper body, you were correct. The upper body of the what? Or basically just the body of the what? Because for this area, we only have a body. Pubis, body of the pubis. Body of the pubis. It's going to be the area closest to that acetabulum right there. Body of the pubis. Let's see. Javier, what is D? These are referring to this area right here where I have my cursor.
Tuberosity.
The ischial tuberosity, you were correct. Now, I don't have a letter here, but what would this be, Jessley? What would this be?
I know it, but it's not coming to me.
Okay.
Isn't it like posterior, inferior, or something?
Not exactly. Now, here's the clue. We have superior ramus right here. This is superior ramus. What do you think this is?
So inferior?
There you go. Inferior ramus. Superior ramus, inferior ramus. Well, let's go to Jolie. Jolie, what is this area in the middle right here? What are we referring to?
Symphysis pubis?
Correct. The symphysis pubis or the pubic symphysis. Okay, and let's go to F. Jonathan, F should actually be, this arrow needs to be right here on this upper portion. That's what it's referring to.
So the superior.
That's the superior ramus, correct. And then let's go to Wani. G is referring to this opening right here, this hole, this big round hole. What is that?
D, it's the obturator foramen.
Correct. All right, let's And make sure, guys, when you're labeling these, remember your rights and lefts. We do have a right and left because there's two hip bones. Therefore, that would be the right obturator foramen, the left obturator foramen, the left ischial tuberosity, the right ischial tuberosity, and so on.
Mr. Donahue?
Yeah.
Did you say C? C was the body of the. Is that the ischium or the pubis?
That should be the body of the pubis.
That's the body of the pubis? Okay.
Yes. Let's go to H. Sharon. What is H?
It's the spine, right?
The ischial spine, correct. So a little hard to see, guys, but it is there. It's that little tiny protrusion right there on the the inside of that brim. That's that ischial spine. Okay, let's go to Luke. Luke, what is I? It's this area around this round shape here, a little socket.
The acetabulum of the right hip?
Correct, the acetabulum.
Acetabulum, yes.
And if you guys remember, I think I said this on semester 1. That's one of my favorite ones. I always like to label acetabulum. I have a favorite one for each chapter. I love acetabulum. Remember that acetabulum. Just one of those fun words. At least to me. I'm a word nerd. It's fun to me. Let's go to, let's see, Naomi. What is L, Naomi?
The head of the right femur.
Head of the right femur, you're correct. Let us go to Ruth. Ruth, what would J be referring to?
It's the right neck of the femur.
Very good. And Pamela, let's do K. K should actually be on this, well, K is actually pointing to the neck as well, but let's pretend K is pointing to this protrusion right here where my cursor's on. What is that?
It's greater.
The greater trochanter, correct. Stephanie, what about this little protrusion down here? I don't have a label on it, but what would this one down here be?
The lesser trochanter.
The lesser, correct, the lesser trochanter. And let's go to Tracy. Tracy, what is M?
Wing, right?
Is that the ilium?
The section's the ilium.
The ala.
There you go, the ala. The ala, that's okay. And then let's see. Let's go back to, let's see, Jaleisha. Jaleisha, what is this little line going across here between the trochanters? Is that a little line?
I see it, but I don't quite remember the name of it.
It's okay. It's between, here's the clue, it's between the two trochanters. So it's the intertrochanteric crests. Between two trochanters, intertrochanteric crests. And what else? What else, guys? Some other stuff I could ask you to label on this x-ray, because this is the money shot x-ray here, guys. Most pelvis x-rays are going to look exactly like this, and there's tons of anatomy we can label. Not just the ones that we went over, but if I said, what bone is this in the middle? You'd tell me that's a sacrum. How about this little tiny one down here? You'd tell me that's the coccyx. Little tailbone. What about these two little joints here? Anybody know what this little joint here is called? We got a very prominent joint there. It's connecting the hip bone to the sacrum.
The SI joint?
The SI joint also stands for the sacroiliac joint. You are correct. You are correct. Anything else? And of course, I could label the brim, by the way, guys. If I'm pointing to the edge of this circular area, that's the pelvic brim. And this area outside the brim, is that the true or false pelvis?
Right is false.
False.
Inside is true.
That's the false pelvis. And then the area inside would be the
It's true.
true pelvis. And last question, is this a male or female pelvis?
Say male.
Female.
How do you know it's a female pelvis?
Oh, female.
It's wide. The angle is wide.
And the angle of what's wide?
The pubic symphysis is wide, and then the brim of the pelvis is oval compared to like the circle, I guess.
Very good. Very good. And you can actually see that inlet area, guys. You can see that the coccyx is not overlapping the pubic symphysis, which identifies that this coccyx is moving more posteriorly as opposed to anteriorly, allowing that safe passage of the baby if this female were to become pregnant. And of course, we have no shielding there either, showing us that is a female pelvis. And then, by the way, even though we haven't done positioning yet, guys, this is always going to be AP pelvis. AP pelvis only has one view, AP pelvis, when it comes to pelvis x-rays. Now, we do separate some different ones when we talk about the hips. But as far as the pelvis, you just got that one view right there, the AP pelvis. Now, I know we haven't went over it yet, but there's a trick to an AP pelvis. There's something you got to do with the feet. Does anybody know what you do with the feet? Have you guys seen that in clinic yet? I don't think y'all have had on this. But
Don't you turn them slightly inward?
Together.
you always touch your toes together, just like that. And what's the purpose of that? Anybody want to wager a guess?
Doesn't it move the femurs in place?
Well, one at a time. I don't know who's.
To see greater trochanter?
So you're on the right track. So yes, it's going to help put the greater trochanters in profile. It's going to try to hide the lesser trochanters as much as possible, but you won't hide them completely. And we'll look more at that here in a little bit. Well, let's go ahead and take our quick break, guys. It's almost 2 o'clock. Let's meet back at 2:05, and we're going to continue on further into our anatomy here. So come back at 2:05. Okay, everybody, let's head on back. We're going to wrap up this anatomy section here. A few more slides to go. Okay, guys, so last view we just looked at, of course, was an AP pelvis. Whoops. Hold on. Hold on, guys, hang on. Can't get my cursor up.
Just enough.
Here we go. Now, this view here, if you remember, there's always that one view that we're going to learn per chapter that I say is the one that everyone struggles with the most. Whereas last chapter, it was that calcaneus view, the axiolateral. Well, the one for this chapter, when we're talking about the hip and femur, the one that people tend to struggle with the very most is going to be the axiolateral projection of the hip, also called the Donnellus-Miller hip. We'll learn more about the actual details of positioning that as we move on. But this is the one that gives people the most trouble, and also one of the x-rays that give people the most trouble just because the x-ray looks kind of odd when we actually visualize it on an x-ray film. But we're actually going to do this to get a lateral view of the proximal femur in the hip joints. And why would we ever do this x-ray? Well, if the patient's femur is severely fractured or the hip is actually fractured really badly and they cannot move that leg, we of course are not going to move their leg around to get the position we need. We're going to opt for, like we do for most trauma cases, a cross-table lateral view. And that's what you see being demonstrated right here. We're actually going to do a cross-table lateral projection of that hip bone, getting that femur in a nice true lateral view, shooting across our table. So this would be a trauma hip that we do for trauma cases. Now, what are we looking at here? The x-ray is going to look similar to this right here. I'll show you what the x-ray looks like on the next slide. But A is referring to the acetabulum. There's the actual hip joint right there, where the head of that femur fits into that little socket. There's your acetabulum. B, of course, is the head of the femur, that rounded off area. C being the neck. F here is referring to the greater and lesser, the greater trochanter, not lesser, the greater trochanter by itself. The greater trochanter in this view will show itself on both surfaces, both sides of the femur. I'll show you a little more on the actual x-ray. And no, it's not the frog leg method. I saw one of y'all put that in the chat. The frog leg method is actually a completely different view that we're going to go over. This is the Donnellus-Miller axiolateral hip. And then E is referring to where the lesser trochanter would superimpose upon the femur. Cannot see on this diagram, but we can see on an x-ray. And then D would be the shaft body of the femur. G would be the ischial tuberosity that we talked about on those other views. This is showing you if we were looking through the patient and an AP with them in that position, there's that ischial tuberosity on G, there's the shaft of the femur on D, and some of those other parts we've talked about already. But this isn't going to make a lot of sense as a cartoon. Let me show you how it looks on an actual x-ray diagram. Right here I have a nice outlined view of it for you. One thing that really helps me when I'm studying anatomy, of course, is to outline it with colors. That's what we can see right here, because this particular x-ray does tend to trip people up. This is that same view that we're just talking about. And here's all that anatomy we just spoke of as well. By the way, the top portion on this x-ray is the anterior surface of the femur. The bottom would be the posterior surface of the femur. It's in this true lateral view. Here's the acetabulum, this curvy line. That's that socket where the femoral head fits into, forming that hip joint. Femoral head. Here's the neck. Outlines here, you can see what I'm talking about. The greater trochanter shows up on the anterior and posterior surface of the femur here. Don't let that fool you. This is not the greater and lesser separated. This is the greater by itself. It's just showing up on both sides. Greater, greater. Lesser trochanter is actually superimposed upon the femoral shaft. It doesn't actually jut out. So there's usually a little line right here. It's going to be our lesser trochanter. A little bit harder to see, but you can see it. Lesser trochanter superimposed on that femoral shaft. Femoral shaft or body is right here. And then at the posterior portion of this x-ray down here is that ischial tuberosity. Ischial tuberosity. Now take a look at this for a couple more seconds because I'm about to quiz you on it. Next film. I'm going to flip this image around. We're going to see if we can label it without the outlines. Take another look at it. Take another look at it. 3, 2, 1. Here we go. Now we're flipping it around. This is the opposite leg right here. Same anatomy though. Let us start. We're going to go backwards here. Let's. Who did I leave off on? Let's see. Jonathan. Let's start with you. What would D be referring to on that X-ray?
The shaft of the femur.
The shaft of the body of the femur. You're correct. Well, let's go to Stephanie. Stephanie, E's referring to a piece of anatomy that's actually superimposed there. So don't let that throw you off.
The lesser trochanter.
Correct. So E is referring to the lesser trochanter. Now F. See. Hold on.
Is that the neck?
Sorry, I was muting that noise for a second for you. Let's go to F as Betty. What is F? Remember, F is referring to a piece of anatomy that's shown on both sides there.
Is it the greater trochanter?
That's the greater trochanter. You're correct. Amy, what is C?
Is it the neck of the femur?
That is the neck. You are correct. Let's go to Daniel. Daniel, what would B be referring to?
Femoral head.
Very good. Femoral head. And Duyan, what is A?
Papillum?
Acetabulum. And then finally, John, what is G?
I'm drawing a blank here. I don't remember.
It's okay. It's here's a clue. It's that it's one of those inferior. It's that inferior area of the pubis below the obturator foramen.
Is it a tuberosity?
Yes.
Ischial tuberosity.
Ischial tuberosity. Good. Good. So making a little more sense. Y'all still on board? And once again, that's that axiolateral projection of the hip, also called the Donnelius-Miller method. You guys will see in lab. I think some of you already went in lab today. Did you guys get to see the Donnelius-Miller in lab today? Those of you that were in lab? Yes, no? No?
We don't go to lab till tomorrow.
Oh, that's right. That's right. You will. So you'll see what I mean. The Donnelius-Miller is quite complex to perform, but it makes a really beautiful x-ray when you do it right. There's a few little methods and tips that we're going to go over here in class as well for it. Now this view here, this is a slice. If I was to cut the person in half, like with an axial slice, I'm looking straight down at the pelvis. That's what we're looking at right here. There's our sacrum right here with our iliac area of the pelvis. There's the SI joint. Then our symphysis pubis down here. And I threw this in here as well because sometimes you'll see this area in between where that cartilage is. These are actually interchangeable. So sometimes you see this area called the interpubic disc. You'll sometimes see it called the symphysis pubis, but both terms can technically be used. Interpubic disc is actually talking about the actual cartilaginous disc itself. But when it comes to labeling on x-rays, We typically use symphysis pubis or pubic symphysis, but don't mix up those terms. You may see both used every once in a while. Probably 99% of the time, it's going to be symphysis pubis or pubic symphysis. The actual technical little spot there with the cartilage is what we call interpubic disc, just for a little factoid there. But you can use symphysis pubis. Don't mix that up. Now, much like every chapter we went over, guys, by the way, that was all the anatomy. Wasn't too bad, right? Not too much more anatomy? Not too much of an overload? We on board good? We always have joints to go over as usual, guys. And guess what? There's not a lot of joints either. You can see there's just 4 joints. Yay, not a lot of joints. Hallelujah. Praise God. That's always wonderful. Yes. So let's go ahead and name our joints. We're going to give the structural, functional, and movement classifications of each. So starting with those SI joints, if you remember, that's all the way up here, where we have the sacrum connected to the hip bone, the SI joint or sacroiliac joint. Those are considered synovial joints. Their function is amphiarthrodial, and their movement type would be limited or gliding joints. Now, the hip joints themselves, hip joint is referring to the area where the head of the femur is connecting to the acetabulum. The hip joint is going to be a synovial joint. Its function is diarthrodial, and it's a spheroidal movement type, also known as ball and socket, much like the head of the humerus fitting into the glenoid fossa. Spheroidal or ball and socket joint. Now that symphysis pubis right here in the middle, where we have the 2 pubis areas connecting on those 2 hip bones, that's going to be a cartilaginous joint. Its functional classification is amphiarthrodial, and it is a limited gliding joint, same as the SI joints. Now there is one more joint that we cannot see, but it is there. It's going to be what we call the union of the acetabulum. Z1, because this links into what I was telling you guys about on that lateral view of the hip. What do you think the union of the acetabulum is referring to? Anybody want to wager a guess?
3 hip bones.
The 3 hip bones fused together at the acetabulum. You're exactly right. So those 3 bones in that hip bone, those 3 areas fused together. Good grief, I can't talk. Must be getting close to 2:30. Those 3 sections of that hip bone fused together in the middle of that acetabulum. And that's what we call the union of the acetabulum, and it is considered a joint. It's a cartilaginous joint. It's synarthrodial. It's also a completely immovable joint as far as movement's concerned. Cannot move at all, but it is a union of those parts to fuse them together, and it is considered a joint. So don't mix that up with the hip joint, because the hip joint's very close to that. Hip joint is the head of the femur linking up with the acetabulum. Union of the acetabulum is the 3 sections of the hip bone fusing together at the acetabular point, bringing those 3 bones together.
Is there any difference?
Oh, go ahead.
Oh, I'm sorry. Is there any difference between limited gliding and like plane gliding?
No, it's just another way to see it.
Okay.
It's a third term you can throw in there. Limited gliding or plane. You can use all 3. It's more so just saying that's in comparison, for example, to like the hip joint. You don't have the free range of motion. It's a more limited base of movement, but it still technically can move. And if you think about with the birth canal, with symphysis pubis, it needs to move a little bit, expand, so the baby can pass through. So it's a limited movement, but not full range of movement. Just kind of like designate a little more as far as the actual movement's concerned. Okay, so when we are in true anatomic position, we are going to be able to see both greater trochanters in profile. We're also going to see the lesser trochanters barely in profile, even though we're not going to see them fully in profile. Now, what am I talking about? Depending on how we have the feet positioned on that true AP, we want the lesser trochanters to actually be almost hidden, superimposed behind the femur, but we still will see them barely jutting out. So technically, in anatomic position, we are going to see greater and lesser trochanter in profile If we do not, something's majorly wrong as far as the positioning is concerned on that actual pelvis x-ray. As far as this angle is concerned here, guys, you don't need to know that. But if you want to know, the head of the femur is 15 to 20 degrees anterior to the lesser trochanter in relation to where it's located on the actual hip. You don't need to know that. That's just for extra knowledge. Sorry, guys, is that really noisy in the background? They're shooting nails in the floor. I think it's really noisy. Okay, guys, so this is showing you what we want to achieve when it comes to rotating the foot. Mostly for when we're talking about doing some specialized views of the hip and the femur. We'll rotate the foot medially or laterally to show different parts of the femur. Now, even though A here says when we rotate the foot medially or inwardly, we're going to actually hide the lesser trochanter and see the greater trochanter in profile. On an x-ray, most time we'll still see that lesser trochanter barely poking out right here. That is okay. The main thing we want to see is that greater trochanter in full profile. And we achieve that by rotating that foot medially, inwardly. Now, when I rotate my foot laterally, my main goal is I want to see that lesser trochanter fully in profile with the greater trochanter almost hidden behind the femur. Just the two big landmarks I'm looking for in relation to internal versus external rotation of the foot. And most of the time we are going to do that inward rotation on most of our hip x-rays, femur x-rays, and pelvis x-rays. The only time we would ever do an external rotation is most time by a special request from the radiologist. It's very rare, very rare. A is going to be your money shot most of the time. Now right here, if we're just lying flat on our backs in anatomic position, in just a plain supine, what are we going to see? We're going to see the lesser trochanter fully in profile. We're also going to see the greater trochanter in profile, even though it's burnt out right here. So in true anatomic position, even though it says lesser trochanter is visible, we're actually going to see both trochanters fully visible in a true AP without the feet rotated at all. Just plain anatomic position is what we're viewing right there. So with these next few slides, we're going to show you what the difference the x-rays look like as we rotate the feet medially versus laterally, how that anatomy actually changes a little bit. And once again, the only reason you would ever do an x-ray like this, because most of our, well, all of our pelvis x-rays, we actually bring both feet in medially. The only time you would do an x-ray like this is if the patient was in a trauma situation, they could not move their legs at all. Now this would be the external rotation, also called the relaxed position. As you can see here on the x-ray, the lesser trochanter is in complete profile, completely exposed, and that is the main reason we would actually externally rotate those feet in that relaxed position, is to put those lesser trochanters in full profile view, because we need to evaluate that area of the femur specifically. Right, does anyone see something peculiar on that x-ray? Where's my QA people? Get your radiologist's eyes out. Do you see anything?
There's a fracture at the right inferior ramus.
Correct. The right inferior ramus is fractured right here. Or is it the left, not the right? The left. And this is the most common type of pelvis that we'll do, guys. Like 99% of your pelvis x-rays, you want to look exactly like this. This is what we call the true AP projection of the pelvis. We're going to rotate those feet inward so that the toes are touching each other. That's a 15 to 20 degree internal rotation. And when we do that, the lesser trochanters are almost not visible. I'll throw that word almost, because as you can see, you can still see the tips of them, but we want them to be hidden as much as possible, and we want these greater trochanters fully in profile. Let me go back and forth here between the two slides to show you what I mean. External, you can see the lesser trochanters are fully in profile. Internal, they're almost all the way hidden. See the difference there? And that's what we want for a true AP pelvis. true AP pelvis. You want those lesser trochanters as invisible as possible, superimposed on that proximal portion of that femur. And then, depending on what we need to see, if there is a really bad hip fracture, we may do what's called an asymmetric rotation, or if we want a lateral view of that femur or hip, we'll actually bring that foot completely lateral as possible. It's going to put the proximal femur into a lateral position and allow us to check for dislocation or certain fractures at the femoral neck, which you see right here. What that's going to do is, if we rotate that foot, the affected side, into a lateral position, as we see right here, the affected limb is going to have the lesser trochanter in profile, much like with the external rotation we went over earlier. It's going to allow us to check for dislocations, inframural neck fractures in that hip area. Again, you really would not opt for doing this most of the time, because if there is a suspected dislocation or fracture of the hip, most of the time you're going to do that Danelius Miller cross table, because this position right here that you see this person in, this would actually risk hurting that person a lot more and making that fracture worse. You wouldn't want to touch that leg typically. You just do a cross table and get that cross table lateral. But it is considered a position if they're able to bear with it. Now, when it comes to shielding, guys, we're always going to shield the males at the testicular area. You're going to use a smaller shield. Of course, most facilities don't have the actual small shields. Therefore, you're going to use the full lead shield. Put it right at the testicular area. And I actually disagree with this image. I would put your shield right below the light. And the reason for that is shields in the x-ray bring the quality down. Still shield your patients, but bring it below the light field. It's going to increase the quality of that exam overall. So male gonadal shielding is required. Female is optional, much like with KBs, abdomen x-rays. Now, this is an example of abdominal and pelvic shielding if you had a patient that was being really demanding and wanting everything shielded. Let's say you're just wanting to look at the hips and not the actual pelvis. You could put a shield over the gonadal area like you see here, leaving only the hip exposed to the light. Still achieve like an AP and lateral hip while still doing protection of the gonadal areas. But this would be an option only if the patient's really demanding it. It's not required. See right here, this would be like extreme shielding if you have a patient that's really paranoid about it. You always got to make sure that if you do take these measures, you leave the area you're actually x-raying completely in the light field and try to collimate as much of that shield off from that x-ray as possible. The more shield you have on an x-ray, the less quality you're going to have overall on this images. And then, like I said, females are optional if they have ovarian shields available. If they do not, you want to use a smaller shield. You're going to put that shield over the ovarian area and hopefully not obstruct too much of that pelvis area. Hopefully, if you're putting it in the right area, the shield's going to be directly in the middle of the pelvic rim, so it's not actually obstructing any of the actual hip and pelvis anatomy. They're very hard to do. You always have to guesstimate where you put that shield sometimes. That would be for females that are really demanding that shielding. This is an optional method, not required. And this right here is just giving you a few examples of what some fractures will look like when it comes to pelvis and hip x-rays. The most common would be a dislocation. Dislocation, much like the humerus, that's going to refer to that head of the humerus being completely outside of the acetabulum. A lot of times they can just knock these right back into place, but sometimes they're so extreme they have to actually go in surgically and repair that. But you can see that head of the femur clearly out of socket. How would you do an x-ray series on this? Well, you'd get your AP like you see right here. For the lateral, you'd do that axiolateral Danelius Miller we just talked about. You shoot across the table, because the last thing you'd want to do is move that patient's leg if it is dislocated like you see right there. This is showing you how a lot of people will have hip replacements. This person obviously has a hip replacement that's out of socket. That does happen. They can have a hip replacement and still get it knocked out of socket, which we see right here. And one thing that's key to note, this is a great question, by the way, because this person did not do this x-ray correctly. Sorry about the noise. This person actually did not x-ray this correctly. Anytime you have a patient that has a hip prosthesis, like you see right here, you have to include the entire hip prosthesis on the x-ray. Therefore, they'd have to go back and do a lower view of this right hip to include the bottom of that prosthesis. That's only for people with hip prostheses, though. You have to include the entire prosthesis on the x-ray. Very important point to remember there. You might want to write that down. Always include the entire hip prosthesis on a hip or pelvis x-ray. Oh, I'm sorry, guys. I'm going past my time. It's 2:30. We're going to stop right there. Y'all got to speak up if I'm going over, guys. I just keep on talking. All right, guys, any questions on what we went over today? That is the majority of the anatomy. We just have a few more types of fractures to go over. Then we're going to jump into the actual positioning portion of this chapter. Much shorter chapter overall compared to that last big one we just went over. Any questions? All right, guys. Well, as usual, I will send you PowerPoint thus far. Also, write yourself a note. We are going to do the final Play-Doh competition on Wednesday. I think you can figure out what anatomy you're probably going to make, but be prepared for that. It's a lot tougher than it looks and sounds. So bring your Play-Doh or whatever you want to use for that final competition coming to you on Wednesday. With that being said, have a wonderful afternoon, guys. I will see you all on Wednesday morning. Bye.